Thank you so much. It's so good to be here in Riyadh again. This is my 5th time to the kingdom, and it's good to see old friends here. So thank you for having us. We're very excited to be here, and it's been a wonderful visit so far. Today, I'm going to talk to you about a subject you all know well. We've all been through the COVID-19 pandemic. It's been a very difficult time for people globally. And I think it's affected everyone, either personally, their family, their friends, etc. So what I'm going to do is walk you through the timeline a bit of COVID-19, talk about the impact on children, some of the epidemiology that has occurred, and also the therapeutics that are available. Remember when the COVID-19 pandemic began, we didn't know what would work. And we kind of threw everything at it initially, and we've learned quite a great deal about the care of these patients, and especially about the unique needs of children. Oops. Sorry about that. First of all, I have nothing to disclose, and I'll try to, okay, I think I got it, where to point this. This is the basic timeline. You can see here, the first COVID-19 case was identified in China in December 2019. You can see that the genetic sequence was shared in January 12, 2020, and the first pediatric case in China was reported in January 2020. The WHO, the World Health Organization, declared a public health emergency of international concern. And again, first pediatric case was reported in Korea on a worldwide level. And again, this was reported by this all timeline was reported by our CDC, or Center for Disease Control. As we move on, you see by March 2nd, the first pediatric case was reported in the United States. This time, there were obviously many adult cases on a worldwide level. And the global pandemic was declared by the WHO on March 11th. On March 13th, the United States declares a national state of emergency. And I know that in 2020, as we were preparing to come to this conference, we all had our tickets, we had our lectures prepared, and we had to cancel. And, you know, kudos to Dr. Al-Faifi and all of his colleagues who really gathered together and worked with us to create an online virtual 2020 conference for the 6th International Conference. So I want to say thank you for that pivot. And I think we had more than 1,000 people online in 2020. On March 24th, the first pediatric death was reported. We often think that children, at least in the beginning, were immune to COVID-19. I know we went over 9 months in Los Angeles without any pediatric deaths. And one of the theories around why pediatric patients don't get COVID-19 is that the way the virus gets in is through the ACE2 receptor, and that it takes a while for that to mature in children. And it turns out that obesity, being a risk factor and is a risk factor for children, obesity upregulates your ACE2 receptor, and that is a reason why children with obesity are higher risk for having severe complications. And as you can see, on April 26th, and this is something very important because this seemed to be unique in children. However, we know it also occurs in adults, but the National Health Service in the UK reported a syndrome, a multi-system inflammatory syndrome in children. And these were patients who were approximately 4 weeks out after COVID-19 infections developed this syndrome, which include multi-organ failure, especially cardiac issues as well. And the first reported death in the United States was reported in May 8th. And again, the CDC on May 14th released that they were seeing multiple cases in New York. I know Italy reported this as well, the multi-inflammatory syndrome in children. So that's the whole timeline. I'm going to move on just to see the impact of COVID-19 on a global scale. This is from the 13th, actually, and by the 21st, there have been more than 460 billion cases, million cases, sorry, that's a lot of people, a lot of infections, 460 million cases of COVID-19 with over 6 million deaths. And this is a map of the world. You can see the darker the blue, the more infection or cases there are. And it's quite disparate all over the world. And I think the reason Africa shows lower case numbers is lack of reporting and testing within the region. As we all know, there have been multiple surges. You can see the 4 surges that have occurred initially with the initial infection and later with various variants. We had our biggest peak in Los Angeles with over 8,000 individuals hospitalized with COVID-19 in January 2020. Indeed, there was another peak with Delta in the summer, and you can see that on here. And you can see where the peaks occurred in various places of the world. And the last peak occurred with Omicron, with many, many more cases, even in patients who had been vaccinated. And we saw a large number of children on a daily basis infected with the Omicron variant. This just shows in the United States some of the diversity around our country. Even you saw it we've seen it on a global scale, but also we saw it in the United States in terms of the number of cases. So let's talk about the impact of children. These are statistics from the US. I tried to get World Health Organization statistics, but it was very, very challenging to get that. So this has been reported by our CDC and the American Academy of Pediatrics, along with the Children's Hospital Association, has really a nice dashboard of information as well as information on therapeutics. So if you go to aap.org and put in COVID, it is public facing, and so anybody can get this information. There's been more than 12 million total cases of COVID-19 in children in the United States, representing about 19%. Initially, it was a much, much lower percent of infections. And that may have been related to what we call the stay-at-home order or isolate in place. And many people stayed in their homes and weren't out and about. In terms of the hospitalizations, you can see somewhere between 1% and 2% of all COVID-19 admissions are children. And again, most of these cases, I will tell you, are generally supportive care. We saw initially a lot of children with dehydration syndromes, gastrointestinal disease, and also respiratory disease, especially those kids who are high risk. Now, the good news is that the likelihood that a child is going to die of COVID-19 is extremely low. And you can see about 0.25% of all COVID-19 deaths are children, and the mortality rate for children in general is extremely low. And this just shows the United States the number of COVID-19 cases that were added in the last week. So this goes through, I believe, March 3rd of 2022. And you can see that with Omicron, we saw a huge spike in the number of children. The good news is that we had tremendous capacity in the United States, but I'm sure that that is not true worldwide. And in the kingdom here, I imagine that you had great capacity to care for children, whereas in other countries or poor countries in the world, that may not be the case. I love this slide because it was a group of PICUs that got together to begin to gather data on children and to track them to see what kind of therapies they received, also what their mortality rate is. And this just demonstrates that there were about 3,300 cases admitted to the PICUs. And I believe this is all in North America, Canada, and the US, in which they gather data. And you can go to vps.org and you can join. There's an opportunity for PICUs around the world to join. So let's just talk about some of the testing recommendations. Typically, patients with symptoms, although I will tell you that with the Omicron variant, the issue was how old they were there issues of high-risk individuals at home? And we became somewhat overwhelmed because of workforce problems. I don't know if you had this in the kingdom, but we saw many people getting ill that were healthcare workers as well, and people who'd been vaccinated with Omicron. And therefore, the healthcare, although the number of cases were high, the severity was relatively low, but it still inundated our healthcare system in the United States, and it was really, really challenging. So sometimes patients with symptoms got tested, other times they did not. They were asked to, after evaluation, to go home. And then patients who are asymptomatic but with close contact to a person with COVID-19, and typically, as you know, the incubation period is about 2 to 14 days for COVID-19, but generally by day 5, if they've been exposed, they should be positive at that point in time. And as we all know that antigen tests, if they're negative, you probably need to retest because their accuracy is about 30%. If positive, their accuracy is much higher in the range of 70%, and PCR testing is considered the gold standard. So what do we do with newborns? And in many hospitals, they test prior to discharge, typically 24 and 48 hours, but in some areas in the United States, patients are discharged within 24 hours after delivery. So the standard is to test them prior to discharge, as the young child is at a higher risk. And then finally, there's been routine testing for school and in childcare or congregate living situations. There's been routine testing. What about clinical presentation? As you can see here, this is a reprint. This shows what we call COVID toes. It's essentially aligns with chilblains, which is considered probably the pathophysiology as it relates to COVID-19 has to do with the vasculitis or a microvascular disease, microvascular inflammation that results in what you see with either red or frankly cyanotic looking toes. Generally, those respond well without therapy. The most common presentation in children was fever. We did see a lot of kids early on. I'd like to, in our question and answer session, I'd like to see what your experiences are here, but we saw a lot with fever, GI complaints, URI symptoms, of course, and then some with shortness of breath, others with petechial syndromes that like their bodies were showered with petechiae, which was really interesting, and papulovesicular rashes as well as urticaria. As you're aware, it was around April and May that the multi-inflammatory syndrome in children was reported, and on May 15th, WHO came out with a report on multi-inflammatory syndrome in children. And the case definition, as you can see here, an individual less than 21, we do see multi-inflammatory conditions very similar to this in adults as well. And as you know, with adults, they were more likely, although children still had effects from the cytokine storm and the massive inflammatory process that beget COVID-19 infections. But generally, we say under 21, and they're typically older than you see with patients with Kawasaki's disease. So laboratory evidence of inflammation, and when I talk about fever is 38 for greater than 24 hours, or the definitions also include subjective fever for greater than 24 hours. And then laboratory evidence of inflammation. So what does that mean? C-reactive protein or ESR, erythrocyte sedimentation rates, procalcitonin elevation, D-dimer, ferritin. These are some of the Oftentimes we do a kind of a stratified approach. Those that we think could have multi-inflammatory syndrome, we can, with some of these labs, especially C-reactive protein and ESR, and then move to the more complex labs such as troponin, procalcitonin, D-dimer, et cetera. So again, with multi-inflammatory syndrome, I'd seen a number of cases. This one child came in that I saw basically was totally awake and alert, but pulse ox was low, just like we see in the adult population. And he had reactive airway disease. We started treating that, and his blood pressure never came up, and we ultrasounded him, and he had severe myocardial dysfunction and ended up requiring an epinephrine drip and intubation. Now, the good news, he was discharged 3 days later. So that was one of the things that we did see with multi-inflammatory syndrome, that some of these kids got severely ill. And if they were appropriately supported, they were able to be discharged. It was pretty remarkable to see him awake and alert with a blood pressure of 60, and yet talking to us, wheezing. And then ultimately we realized that we needed to intubate him. So we supported him, gave him pressor agents, intubated him after we tried with fluid support and inotropic support, and then he went to the PICU. So anyway, there's no alternative plausible diagnosis for these patients. So it's kind of a diagnosis in which you need to consider all factors. And as you know, there's a number of causes of myocarditis besides what we see with multi-inflammatory syndrome, but it is something we need to look for. And then the other thing would be a positive for current or recent SARS infection, and generally it's within 4 weeks, or they could show antibodies. The other thing that you see is reduced lymphocytes and low albumin. When we look at the various diseases, I think it's important to see that there's overlap between Kawasaki syndrome as well as toxic shock. So some of these patients early on presented as if they had toxic shock. The other thing, there's overlap, and this is a severe condition that is sometimes congenital, which is the hemophagocytic lymphohistiocytosis and macrophage activation syndrome. We do see hereditary versions of this. It can be acquired, but there was some overlap with this. But that has a much higher mortality rate than we see with the multi-inflammatory syndrome in children. So what are some of the key differences you can see on the slide? With Kawasaki's, they're often younger, and these kids were over 5, and we saw teenagers with this. Presence of abdominal findings, as I mentioned before, and I saw many patients that had GI symptoms. We had several that had pretty severe colitis that were COVID-19 positive. And then as the case that I quickly told you about is higher rate of cardiac involvement on presentation. So you really have to balance your fluid resuscitation with your pressor, and that can be very problematic. And some of these kids are on afterload reducers as well. And again, like our patient presented in profound shock, although he was totally awake and talking to us, which I found very remarkable. Just like I saw with many, many adult patients for which they had pulse ox of 60%, and yet they were awake and talking to you. I had never seen that before in my career until COVID-19. So it's clearly a unique disease. And then thrombocytopenia and obviously increased cardiac markers. And this is just some of the screening that you see. Generally the CRP is elevated, ESR, the lymphopenia, thrombocytopenia, hyponatremia, and abnormal creatinine, just stating that it's multi-inflammatory and it involves multiple organ systems that we saw. And there's a huge number of signs and symptoms of MIS-C, as you can see here, and some of them are typical of Kawasaki's, such as conjunctivitis and lymphadenopathy. Other labs that we would consider, I would certainly get an EKG on them to look for signs of ischemia. I did not see that. We initially saw tachycardia, and this child became a little bradycardic, which made me very scared for a while, but it came up with our therapy, including really oxygenating him appropriately. And, but you can get troponin, you can get BNP, obviously the COVID PCR, and then consider other causes, because some of these kids, you know, is this toxic shock? Could this be septic shock? It can be really challenging. So we often did blood cultures and empiric antibiotics. So in terms of support of these patients, it's really supportive care. Studies now have shown that using IVIG is very useful along with steroids, that combination in particular. And as you can see, the methylprednisolone dosing is there for you. And then for some of the thrombotic complications that we saw, aspirin for young children, and then enoxaparin or Lovenox for older kids. The other thing is we see that the long COVID syndrome is definitely real for children, and this is something to consider, kind of that neurologic fog, depression, those types of things, I think, difficult in terms of being able to exercise and some of the respiratory symptoms. And there was a study looking at the multi-system inflammatory syndrome in children worldwide, and the UK sponsored this, and there were really well over 100 children worldwide with this syndrome, although it wasn't, and who knows, that was what was reported. I'm sure it was more common than that. When we talk about COVID-19 in general, some of the diagnostic studies that we often use, depending on their presentation, was getting an ECG, certainly chest x-ray with those with respiratory symptoms. Most of the children I saw were young, febrile, looked like they had a viral illness, were COVID-19 positive. We saw a lot of kids with croup that had COVID-19, also some that seemed to have more of a bronchiolitic syndrome with COVID-19. So again, you would treat based on those symptoms, and certainly use of steroids in kids with croup seemed to be useful. And then finally, using point of care ultrasound, looking at the lung and cardiac. And as you can see here, you get with the lung, what you often see with COVID-19 is you get an irregular pleural line, and you can see that here, and these B lines. Okay, and there at times were areas of consolidation as demonstrated here. So it could be quite useful in order to diagnose this. Originally in China, they were CT scanning all the children, found ground glass appearance, but stopped doing that because, again, you should treat them symptomatically, and some of these children got radiation that really didn't need it. So I think just a simple chest x-ray is fine, and then treat symptomatically. So now we're going to talk about therapeutics, and certainly oxygen, use of high flow nasal cannula, and intubation as needed. But early on, we were intubating everybody, and they thought early intubation was the way to go for adults and young adults, but that really wasn't the case. And we moved to a high flow nasal cannula. And the rule was 2, 4, 6, 8, meaning, and then you have to intubate, is how we thought about it. And then approximately May of 2020, remdesivir became available in the United States. And this was, this and the fact that they showed that dexamethasone decreased mortality in patients in the ICU was a godsend, because it just meant that we had something that we can give that might make a difference. And probably what we've learned over the pandemic is that the earlier you give remdesivir, the better. And as you might be aware of, the indications at first were the most ill, And then we backed off to anybody who needs oxygen, and then anybody who's hospitalized, and then anybody who's high risk, who's not even admitted to the hospital. So I think the earlier you give remdesivir, the better, and it's done on a milligram per kilo basis. You can either do a 5-day or 10-day course, although studies in adults have shown that there's no real clinical advantage of going 10 days, but some would go 10 days based on the fact that they were critically ill. And then dexamethasone is given. You can see the max is considered 6 milligrams a day, which is the adult dose, up to 10 days. And again, the IL-6 inhibitors have also been used for adults and children. What about some of the antivirals? And I think there's going to be expanded use of the antivirals as we go along, as well as the monoclonal antibodies. And as you know, the monoclonal antibodies have been a bit of a moving target. We started out giving bamlanivimab, and then etesevimab we added, and then there was resistant to that, Regeneron, which is casirivimab and indapamab. And so those were given, those were quite effective with Delta. But in California, we had a California variant, which was a UK variant, and we could only use, we could not use bamlanivimab early in the pandemic. So we had to switch to Regeneron. But now we don't use either one, right? So I'll talk more about that in a second. But who should get these? Again, these are the newer monoclonals are approved for children 12 and older, and, at least in the US. I think that's probably true globally. And it would be great to have a discussion of what's available here in the kingdom. But as you can see, obesity was a big risk factor. Immunocompromised disease is really important. Neurodevelopment disorders, this is different than what we do in the adult population typically. And then medically related technological dependence. So those kids who, especially with tracheostomies, or require positive pressure ventilation at night or during the day, and those with gastrostomy tubes. Sickle cell, chronic disease, very common in the adult population as well. Diabetes, common in all age groups, again, as well as chronic kidney disease and liver disease. So these patients are high risk. So if they had COVID-19, they could get it within the first 5 to 7 days or so. So we're going to talk about outpatient therapies. The remdesivir I talked about, as well as the IL-6 modulators, and dexamethasone are inpatient. But outpatient treatment, remdesivir can be given. It's on a milligram per kilo basis, very similar to what is done in the inpatient, but it's only done for 3 days. And these are for high-risk individuals that have a chance of getting severe COVID-19. And that's the list I just went through with you. The Paxlovid, sorry, I'm getting too close to the mic. 12 years or older, and again, within 5 days of onset. And this has been shown to be highly effective. And I think we'll see much more use of Paxlovid, maybe even very similar to how we use Tamiflu for influenza with the high-risk populations. And then molnupiravir, which is another antiviral, initially looked very promising, but the efficacy is much lower. And it's complicated by the fact that you can't take it with many, many other medications that are given, including statins. So this really has limited its use in the adult population, and it's really not used for children, but I just thought I would mention it. And the monoclonal antibodies that we're using now is the sotrovimab, which is something that we have allocated to many, many centers in Los Angeles. And this is given over 30 minutes. And then the bebtelovimab, which recently came out, both of which are effective against Omicron. And the thing that was really great about the bebtelovimab is that it can be given in a single injection, which is fantastic news. And then finally, Evishield, which is given differently than the other two. And these are pre-exposure prophylaxis. This is a combination monoclonal, as you can see, and it's given in 2 separate IM injections, and it lasts for about 6 months. So these are for the immunocompromised transplant patients, those who really can't mount a response to COVID-19, and it can be given before they get it. So if they're undergoing chemotherapy, if they are post-transplant, these patients can be given this even before, and it's supposed to be given before they develop COVID-19. And finally, this talk about COVID-19 would not be complete without discussion about vaccination. As you can see, children have very low mortality, but we really don't know the full impact of COVID-19 in the pediatric population in terms of long COVID or other long-term complications. But what we do know is that the vaccines are very effective. And the 3 that I'm most familiar with are Pfizer, Moderna, and the J&J vaccine. And as you know, there have been multiple reports about the myocarditis, pericarditis that you see post COVID-19 vaccination. We've seen that not that commonly, and most of these children they have chest pain, they may have shortness of breath. They may have some cardiovascular complications, but they generally do quite well within a couple of days. There have been some concern about some of these kids dying, but it's very, very rare relative to this, extremely rare. And if you think about that, over 10 billion doses of vaccine have been given globally, the fact that there are in the range of 1,000 cases of the myocarditis syndrome reported is extremely low, and the risk is very low. When you look at those approved, you can see that Pfizer is really the one that is approved for children. Otherwise, the 5 to 18-year-olds, and otherwise Moderna is available. And that's the end of my talk on COVID-19. I know this has been a challenge for all of us. I really appreciate that we've hung in there throughout this time. These are various snapshots of things. We had a flyover by our military for all of our healthcare workers, and literally people all over the United States and various things. They came in and they honored healthcare workers. And it was quite moving to have that done, and that was during the week, EMS week, and we also had our U.S. naval ship Mercy come to Los Angeles to help us during the pandemic. And you can see in the lower left, this is our medical alert center. We were really on call 24 hours a day, probably for over a year in the beginning, working 7 days a week. And it was really impressive to see the number of people who really chipped in to try to help with the pandemic. And then on the lower right is our warehouse. We distributed over 60 million pieces of PPE to Los Angeles and all of the therapeutics. So it was a busy time for me during COVID-19, but it was one that I think, as Dr. Alfalfi said, that he was very proud of the response, and I feel proud of all of our healthcare workers, both in the United States and abroad, and thank you for all that you do.